Hi guys, John Adamson, the Rehab and Documentation Guru. So I've been looking at some notes from other therapists recently, and one of the things I see as a common issue, not just notes for therapists, but notes for any healthcare provider, is that they don't know how to write a good reason for referral or initial analysis statement. They leave out some really important information that forms the basis for some of the medical necessity of their claim. So what I'm going to do today is I'm going to go over the formula for writing a decent reason for referral. And then, for those of you that have been to my course on Documentation Bootcamp, I'm going to be including a new reason for referral that will hopefully give you a little different perspective on what I'm talking about. So there are some formulaic ways to look at how to write a good analysis statement right off the bat for any new patient that you're looking at. So one of the things we include obviously is pertinent patient information. It's amazing to me how many clinicians just leave this out, but things like the patient's age. Now gender is probably going to be either obvious or it's going to be stated somewhere else in your documentation. Also, you want to include things like the referral source and the reason for referral. And number 3 is tied into that, the setting the patient's referred from and to and why. What's the reason behind that? So if they're sent to home health versus inpatient or inpatient versus home health or home health versus outpatient, is that evident from what you have written in your reason for referral? Now, in the next sample that you're going to see on the next slide, I'm going to actually be leaving that out because I tried to make it more of a generic patient that could be seen in various types of settings post-acute care. But one of the things we're going to talk about is basically a summary leading up to why they're being referred to therapy in the first place. And then we're going to talk about medical diagnoses and then treatment diagnoses, things that you're seeing that are causing number 1, the coding of ICD-10s, because ICD-10s drive reimbursement, and number 2, the actual medical events that are causing functional declines in therapy. And then we're going to summarize just some of the findings, what's going on with the patient that's gone downhill, and the things that cause them. So underlying impairments are your causes of your functional deficits. And then never forget, in any analysis statement of a patient that you're just starting for therapy, anything that's significant from a comorbidity or a complexity standpoint should be mentioned. And we're going to look at a little bit of a unique situation with the next patient that PTs don't always think about documenting. OTs are probably a little bit better about it, that are going to be impactful on the patient's care. And then finally, a statement of medical necessity. And we want to paint the picture of this is why they need therapy and this is what will happen without. So without further ado, let's look at our sample. So we have this 42-year-old female, recently divorced, obese, was hospitalized due to MS exacerbation on 4/27/20 and was inpatient until 5/12/20. Okay, let's stop there for a moment. So what do we know about this lady? We already know that she's fairly complex. She's young, 42 years old, not your typical patient that we would probably see, but she's got a lot of things going on. When we talk about complexities and comorbidities, she's got 2 that are named right off the bat. She's recently divorced, and we don't always look at the psychosocial aspects of our patients, and this is a major stressor in this lady's life. We're going to find out more about that in a little bit. And she's obese, and that is a multifaceted complexity with lots of associated comorbidities. And she was hospitalized because of her MS. So we know that she has a long-standing history of MS, and now it's been exacerbated. And she had about a 15-day inpatient stay, which is really a long time. And probably we wouldn't see that with just an MS exacerbation, but we're going to see why she was in the hospital for so long. Leading up to her hospitalization, she declined in function over the course of 1 week. So this is a very rapid decline. And she went from being able to walk with a cane to being non-ambulatory. So this is a really big, drastic decline necessitating hospitalization. During her hospital course, so now we're going to find out why she stayed in the hospital so long. She was given high-dose steroids, which would be expected with an MS exacerbation, and developed diabetic symptoms We know that high-dose steroids can cause patients to have abnormal blood sugars. She also developed high blood pressure and fluid overload. So she's obviously developing the symptoms of CHF, and with the obesity, with the diabetes now developing with the high blood pressure, that's not surprising. So this has extended her stay. So we've got a pretty complex patient right off the bat. Her functional declines as a result of exacerbation include transfers, gait, and ADLs. See eval for findings. So this is important. In the body of our eval, we're going to have specific measurements associated with those. These functional deficits are caused by significant weakness of bilateral lower extremity and shoulders especially. So you think about that. If her legs are very weak and her shoulders are weak, she can't stabilize with her upper extremities. Think about all the things she won't be able to do. So anyway, she's got weakness, increased tone impacting posture and her dynamics with gait, lack of coordination, and balance dysfunction. So what we're seeing in this first paragraph is not only a fairly good synopsis of what happened, but we're seeing a number of diagnostic opportunities. We've got this exacerbation of MS. We have abnormality of gait. We've got, what else? Lack of coordination. I know these aren't all strong diagnoses, but taken together, they paint a much bigger picture of the problems this lady has. Hypertension. If we have a diabetic code from the doctor, that would be good. So anyway, she's got all of these things going on, but let's find out more about her that will fit the bill of the different points I was bringing up on the last slide. Patient was living on her own, doing her own shopping, driving, walking with a cane with a limp, and was working as a receptionist. So she was working full time. She just finalized a divorce from her husband of 19 years, so this is a lady who's probably dealing with a lot of sadness, and has 3 children at home who she drove to all activities ages 6 to 11. So these are young kids. They're, maybe the 11-year-old is going to be fairly independent in some respects, but these are kids that are going to need a lot of guidance, a strong mother at home. She was dealing with significant depression as a result of her perception that she will lose her children. And so right off the bat, I mean, this lady's being hit on all fronts, psychologically, emotionally, physically. So this is going to be a complex patient. Her blood pressure and blood sugars have been erratic since discharge from acute care, necessitating careful monitoring and a high level of complexity related to modifications of mobility and ADLs, goal formation, and activity prescription. So when we're looking at a patient that we're going to have to show that we are needed to see them for skilled therapy, one of the things that we want to point out is just the complexity of the approach to care, because Medicare pays, again, I've said this in other videos, on the complex nature of what we do and the complex nature of the clinical presentation. So this lady's got a lot going on that we need to be monitoring carefully. We're going into this lady's visits, monitoring her blood sugars, while asking her what her blood sugar readings were, monitoring her blood pressure, probably asking her about how she's dealing with her depression. There's a lot of things we've got to deal with this lady to modify our approach that we as therapists with a lot of training in biophysical, psychosocial aspects of care are going to be well equipped to handle safely and effectively that a non-skilled person would not be able to handle. And finally, it says skilled therapy is medically necessary to restore her to her prior level of function, which is possible. I mean, she had a rapid decline and then she got this high dose steroids. Maybe she'll come back. Okay, so restore her to her prior level of function, or highest, practicable level of function. So what's practicable level of function? Well, it's attainable, what we expect to be attainable for her without therapy. So here's looking at what's going to happen, we believe, if we don't see her. Patient will decline further, remain at a higher level of dependency, including not returning to home, which is obviously her huge goal, is to get back to her kids. and greater caregiver burden. So she will go from being the caregiver to being cared for and reduce quality of life. So this lady, she's got a lot going on. She needs therapy. And this statement makes it pretty clear right from the beginning. We're painting a picture. We're telling a story to the reviewer. If I don't get involved with this lady, she's going to have further problems. I need to do something about it. And that's the nature of the game, right? Telling a good story. So I want to thank you for watching this video. I like to do these kinds of presentations once in a while. If you got something from this, please leave me comments. If you didn't get something from this, please leave me comments as well. If you have any suggestions for further videos, I appreciate those. I don't get to everybody's questions or emails or comments they make on my YouTube channel, but I try to get to as many as I can as time allows. Anyway, hope you're having a great night. Take care. God bless.